you two are engaged again.
Yes.
Yes.
For real. Yeah. You're sure you want to go through with this? Because one wrong answer, I'm going to take you down.
So they can appear in the iris, the ciliary body, the choroid, the retina, and retinal pigment epithelium. And I've divided all the different types of tumours under the particular eye structure that they affect. So in this presentation, I'm going to tell you
Ron, what's up?
that you are most likely to see clinically, and the presentation will be ordered according to the tumour type, irrespective of where it is in the eye, where it occurs, in what structure. So, for example, if I'm talking about nevi can be found in the iris, and they can also be found in the choroid.
All right,
so
sharp.
as a whole, I'll tell you about nevi generally.
It's the weekend.
Melanomas can be found in the ciliary body and the choroid and the iris, and I'll tell you about melanomas in one section. So this is how the presentation will be structured. So let's start by having a look at nevi, or nevi is the plural for nevus. And we'll have a look first at nevi that occur in the iris. They can also occur in the choroid. So an iris nevus is a pigmented,
So what's up with you this weekend?
Sometimes slightly elevated tumour, and it's usually less than 3 millimeters in diameter, so very small. What it does is it disrupts the structure of the iris and can cause distortion of the pupil. In the image at the top there, you can see a brown area, which is the iris nevus. It's just here, and you can see that the nevus is pulling this pupil slightly out of shape. So this is where the disruption of the iris is occurring in this particular nevus. In this image below, we've got a choroidal nevus, and the choroidal nevus is fairly common. You will see these clinically.
All right.
Present in about
I see.
5 to 10% of Caucasians, and usually they are present at birth, but they do grow.
You guys are still on a break?
And often the patient doesn't have any symptoms, and it's just detected on a routine examination. So what you will see is a very typical oval type shape, and it's usually a slate colour or a grey lesion, and it has what we call detectable but not sharp corners.
Oh, okay.
So if you were to take a pencil and try and draw exactly around this nevus, you would have some difficulty actually defining the edge. Now, what you need to notice in this image here is that the retinal vessels run over the nevus. You can see the retinal vessels here. And it's because these retinal vessels are more forward than the nevus. The nevus is down in the choroid, so you know it's actually under the retinal vessels. What you can also notice is with the nevus, it's not distorting the shape of the retina or those vessels. They are just continuing their normal course. We will now have a look at melanomas, and we'll start by observing iris melanomas. These can be either pigmented or not pigmented. So here they are. This is a pigmented iris melanoma, and this one here is a non-pigmented one. And they can usually be seen in the inferior section of the iris area. They're usually about 3 millimeters in diameter and approximately a millimeter thick, so they are very small. Now, they can also distort the pupil just like an iris nevus can. They are quite common, or people with fair skin, I should say, are more predisposed to having iris melanomas, and the light iris colour in fair-skinned people puts them at greater risk of developing either an iris or a uveal melanoma. Of all uveal melanomas, 3% of those will arise in the iris. So usually they have a good prognosis.
What am I drawing next?
5% of people who have an iris melanoma will develop a
What am I
metastasis
drawing
within 10
next?
years. So unfortunately that will spread through other structures of the body. So the patient would usually come in their 50s or their 60s, and they will complain that they've got an iris lesion that is getting bigger over time. Sometimes the melanoma can also grow along the iris surface and can invade the angle, and this is what's happening here. So here we've got the cornea, and
The DJI Mini 5 is out.
invaded, or the angle of the anterior chamber rather has been invaded by that melanoma.
But it won't be available in the
Melanoma
US,
here is found in the ciliary body.
unfortunately.
And you can see it on the image here. We've got the pupil in blue, and then
Thank you,
looking
Ephraim.
through the pupil, sorry, the iris in blue, and you're looking through the pupil, and you can see the melanoma just there, that is yellowy.
Thank you for the likes.
Structure, and it's sitting in the ciliary body. So 5% of all uveal melanomas arise in the ciliary body, and a patient will attend usually in their 60s, and they'll complain of having reduced visual acuity. And you can have a look in the eye and see very large tumours, but sometimes smaller tumours are going to need pupil dilation in order to view them, and gonioscopy rather than just with fundoscopy. Occasionally the melanoma can also be discovered on routine examination if the patient's just going in for an eye check with their eye specialist or optometrist or orthoptist. The melanomas shown here are choroidal, and these are the most common primary intraocular malignancy in adults. 90% of uveal melanomas will actually arise in the choroid, and about 5% per million people per year will develop a choroidal melanoma, and that's actually quite a few people. It affects males and females equally, and what you notice is an elevated subretinal dome-shaped mass. And the reason that it's subretinal is because it's in the choroid, and the choroid actually sits under the retina.
Can't find my eraser, so I'm just using the blending.
Pigmented.
The needed eraser.
And it's elevated. It looks elevated because it's pushing these retinal vessels and distorting them. The melanoma down here is what we call
Let's see what I'm drawing next.
where it's not pigmented.
I think I'll
It's a
do a
dome-shaped
background
again,
for
and it's just like a little ball pushing the retina upwards.
this drawing.
So what they actually do, these
Let's do a
melanomas,
background.
is they penetrate
So I
the
just
ducted
draw.
membrane of the
Let's
choroid
do
and the
this.
retinal pigment epithelium, and they herniate into the subretinal space.
What's this?
And they will invade the scleral channels that are there for blood vessels and
I
nerves.
think
to
I'll
pass
just do
through.
it tiny.
And because they're in this zone,
Let's bring this down.
they can very easily spread
Sorry.
around the orbit. They will eventually
Bring this
invade the
down here.
vortex veins, and once they're in the venous system, they can metastasize and spread to the liver, and sometimes they can also spread to the
Okay.
lungs and the bone and the skin and the brain. So they can be quite nasty if they become metastatic.
I hope it's not blare out there.
The next lesion that I'll tell you about is what we call a chirpy. Now, chirpy stands for congenital hypertrophy of the retinal pigment epithelium, so chirpy for short. And these are a
I
very
go
common
somewhere.
benign lesion as opposed to a
Do
choroidal
this.
melanoma. And so they look quite similar, but these are found in the retinal pigment epithelium as opposed to the choroid.
Should I
And they
study?
don't tend to
So
spread or
I think
metastasize.
this is
Now,
fine.
they can be either solitary, as you can see the ones shown here, or they can hang out in a little group,
This
maybe two or three. Oh, this one here has got a little group of them. These two are solitary. And they can also be what's known as typical or atypical. So, a solitary chirpy is flat, and it's usually dark grey or black, and they can be round or oval, as you can see in these ones here. They have discrete margins, and that means that if you were to take a pencil and try and draw around the margin, it's quite clear where the chirpy margin is. So this is quite different to a nevus. The nevus tends to have more feathery edges. Sometimes they can also be depigmented, like the one in the top image, but usually they're dark colour. This slide here is showing you a grouped chirpy, and they are multiple lesions which are arranged in a pattern, and usually just in one area of the fundus. So the pattern simulates animal footprints, and so we sometimes call this bear track pigmentation, like that. So it looks like a little bear has walked across the retina. If the bear tracks or the chirpies are depigmented, as it is in this image below, then we call this polar bear tracks because they're white as opposed to ordinary bear tracks, which are the dark pigmented lesions. So smaller spots tend to be located more centrally, and as I said, yeah, they can be depigmented completely, but this is less common. You're more likely to see these bear track pigmentation chirpies if they're in a group. So let's take a look at choroidal tumours now. So we've already talked about choroidal nevi, and we've talked about choroidal melanomas. So in this section I'm going to tell you about hemangiomas, melanocytomas, and metastatic tumours. So we'll start with these choroidal hemangiomas. These are vascular hemeromas, we call them, and they're present in two distinct forms. They can be either a discrete or a diffuse form. Patients will usually come to the clinic in their 40s or 50s, and they'll say that they've got blurry central vision and will present with a central visual field defect and metamorphopsia, which is when you have distortion of straight lines. And they'll also have hypermetropia if the retina is elevated by either fluid or the tumour. Sometimes they can be asymptomatic. And what you'll see if you look into the eye is this oval mass with indistinct margins, and it's just there. It's just under the macula there, and it's the same orange colour usually as the surrounding choroid. So it's a little bit tricky to see, as opposed to, for example, choroidal nevus. This choroidal nevus is actually considered this choroidal hemangioma is actually considered a discrete hemangioma because you've got one and it's just sitting there solo and it's only in one zone. A diffuse choroidal hemangioma will affect over half the choroid, and so it's all around here. There it is there. It's quite hard to see. What you notice is that the fundus is very deep red in colour, and these hemangiomas, diffuse choroidal hemangiomas, will enlarge slowly over time, and they will only occur in patients with a condition called Sturge-Weber syndrome, which I'm going to show you in the next slide. Sturge-Weber syndrome is a congenital condition where patients develop benign tumours of the brain, the skin and the eye. And what happens is they get this
running out of space. My goodness.
over the area corresponding to the distribution of one or more of the branches of the trigeminal nerve. And usually the patient has a lesion which is unilateral. And you can see this lady here has got the port wine stain over the left side of her face. So these branches of the trigeminal nerve that have been affected in her. And then this fellow here has got the same thing. It's on the left-hand side. So usually they are.
So I've just got the outlines. I'm in sketched out.
These choroidal tumours as well.
I'm just going to detail it out.
Let's move on to
So
melanocytomas.
we go some more.
Melanocytomas are heavily pigmented tumours, and they're dark brown or black in appearance, and they have feathery edges, and often they're located within the nerve fibre layer, and they can be either elevated, as is this one, or flat. So if you see a dark area around the optic nerve, the retinal nerve fibre layer being affected, you can assume more likely that it's a melanocytoma as opposed to, say, a chirpy, for example, which kind of looks similar, or a nevus. So they're always found around the optic nerve head, and actually more common in dark-skinned people and more common in females. These can also arise anywhere in the uveal tract, not only at the choroid. Now, the choroid is the most common site for uveal metastases to occur, and it accounts for 90% of tumours, the location of the choroid. Now, usually though, metastatic tumours are overshadowed by the patient's general illness because they're a secondary condition to, for example, breast cancer, which commonly occurs in women, and lung cancer in men. And the patient will complain of decreased visual acuity, usually only around the macula. And you'll find that these choroidal tumours are fast-growing, creamy white lesions and can have multiple sites. And both eyes can be involved in up to a third of patients. And what happens with these tumours is patients will commonly also develop a retinal detachment. And the final
I hope it's not
tumour in
blur.
this presentation is a retinoblastoma. Retinoblastomas occur in 1 in every 17,000 live births, so they're fairly common, and they are the most common primary intraocular malignancy in children, and they account for 3% of all childhood cancers. And what happens is they grow into the vitreous or the subretinal space, and they seed tumour cells throughout the eye, and they will cause a retinal detachment. They'll then seed into the optic nerve and eventually spread to the brain.
Hello, Driss.
And will have diffuse infiltration into the retina, so they'll get into the retinal spaces too.
Welcome to my channel.
Eventually, they'll metastasize and go into the lymph nodes, the lungs, the brain, and the bone. So they can be actually quite fatal. So early detection and treatment is of utmost importance. So the top image here shows orbital inflammation, which can occur with a retinoblastoma, and down the bottom here, this poor young child's actually had orbital invasion. You can see the tumours growing quite badly around that eye. Usually they're detected pretty quickly, so it's unlikely that you would see a patient at this stage, but you may well certainly see one with just the inflammation. So what signs and symptoms should you look out for? Well, the child will come into the clinic usually in their first year of life, or maybe second year, depending if the condition's bilateral or unilateral. And leukocoria is noticed firstly, and it's found in about 60% of cases, and that's this abnormally white reflex out of the pupil. Now this should be red because you get a red reflex as the choroid is shining nice and brightly back at you. However, this isn't the choroid, the whiteness, it's a tumour. So this is the first sign that's noticed. And about 20% of children will have a strabismus, an eye turn, in association with their retinoblastoma. They also sometimes develop secondary glaucoma, which is shown in the image at the bottom here. And retinoblastomas are treated with chemotherapy, cryotherapy, or enucleation. And as I said previously, they need very fast treatment before they metastasize to the rest of the body. And when they do, they can be potentially fatal. Okay, so we're coming to the end of this presentation on tumours, and let's just go back and have a look at them again. So tumours can occur in the iris, ciliary body, the choroid, the retina, and the retinal pigment epithelium. Of all these tumours, it's a good idea for you to have a good understanding of the differential diagnosis, particularly between, you should understand iris nevus and iris melanomas and ciliary body melanomas. Other tumours that you should have a good understanding of are choroidal nevi and choroidal melanomas. And
So this is
the
just a
other one
tiny
that is a
drawing
good
over
differential
here.
diagnosis to understand is the difference between a chirpy, for example, and a choroidal nevus. It's very important that you know how to differentiate between these two.
Hemorrhage. These are all very common things that you're going to see in clinic. So the pinguecula is a type of conjunctival degeneration in the eye, and a lot of times it won't be noted unless it's by you or the patient, and it's only noted visibly because these don't cause any symptoms most of the time. When you look at a pinguecula, you see a grossly yellowish white deposit in or around the limbus. And what is the limbus? The limbus is that area where you transition from sclera to cornea. So it's right around the periphery of the iris. The majority of pinguecula are asymptomatic, and when they're present and when the patient complains about it, usually what they're complaining about is either, I don't know what this is, or get this off of me, this is ugly. So this is really only a problem if there's a cosmetic concern, but the pinguecula itself is absolutely harmless and you don't need to do anything with it. But more important than what the pinguecula is and what it means is what the pinguecula stands for. And pingueculas are directly correlated with UV light exposure, and obviously being exposed to UV light, having your eyes exposed to UV light, can lead to a lot of other things, such as photokeratitis. So, when a patient has a pinguecula, it's a sign that perhaps they have been not wearing sunglasses outside, they've been getting snow glare, and so forth. So, this is a sign of UV light exposure. UV light exposure is directly correlated with the risk of developing a pinguecula. That being said, it is most common to get a pinguecula on the medial part of each respective eye, and imagine why that is. You have your nose reflects the sun, reflects those UV rays, and it reflects it right back into the medial portion of your eye. So the medial part of your eye is really getting the most UV radiation compared to the lateral part of each respective eye. The diagnosis here is clinical. This is a very simple diagnosis. Yellow-white deposit near the limbus. It's a pinguecula. Treatment is just reassurance. This is totally normal. You don't need to worry about this. Patient education. Wear sunglasses if you haven't. That will reduce your risk of getting more in the future. And in very limited cases, the pinguecula can become inflamed and uncomfortable. And if it is uncomfortable, if you have the typical clinical case of pinguecula, but it's uncomfortable, then you can use topical corticosteroid drops. So here's an example of a pinguecula. So right on that limbus, right on the periphery of the iris. Another one. So pinguecula comes from Latin pingue, and pingue means fat. Okay, pterygium is a benign growth of conjunctiva, and typically it extends from the conjunctiva, usually the medial part of the conjunctiva, to the cornea. And it tends to take on a wedged or winged shape. And as a matter of fact, if you think of the dinosaur pterodactyl, where it gets its name from his wing, because those dinosaurs can fly, and pterygium comes from the same base Greek word. Pteri means wing. So this refers to its winged shape or its wedged shape. This also is associated with excess exposure to UV light, as well as exposure to sand, smoke, wind, and other things. Anything that can really irritate the conjunctiva. The patient may or may not have associated symptoms. If there are symptoms, the symptoms are going to be foreign body sensation, because you really do have a foreign body in the presence of unusual tissue.
Welcome to my channel.
Developing on the conjunctiva, tearing, dry eyes,
Currently
and so
drawing
forth.
Naruto.
If the pterygium is large enough to where it
Freehand.
crosses into the pupil, then certainly that will alter vision, because it's going to
I hope you
distort
like
whatever you're seeing. So we don't want to wait for the pterygium to invade the cornea.
So what I did is do a
Therefore, we
freehand
want to treat
sketch,
this as soon as possible.
okay,
If
of the outlines,
pterygium
and now I
invades the
just
cornea, you can get corneal scarring,
draw it
and
out.
that would be problematic. So we want to treat these ASAP. And the way these are treated, you're going to refer them off to an ophthalmologist.
Trying to get every
Either
proportion right.
radiation or surgery. There's other professionals, non-ophthalmologists, who may have experience in this procedure, but this is usually a referred procedure that's done by somebody who's got some training in it. So irradiation or surgery. So unlike a pinguecula, a pterygium requires treatment. And the reason is because a pterygium will grow into the cornea and will invade the cornea, and also it will also cover the pupil, and that alters vision. So here's a pterygium. You see you've got conjunctival tissue here. That conjunctival tissue is all the way over past onto the cornea and actually in front of the pupil. So this is kind of analogous to a synechiae. Remember, a synechiae is where you get the iris tissue attaching to the lens. Here we have conjunctival tissue attaching to the cornea. This is a pterygium, a wing.
I did see a synechiae at work today.
So another one, a little more severe. So it looks just like conjunctival tissue.
Patient had surgery
Covering up
somewhere around
cornea.
March last year. Not this year.
Parts of the iris.
At the peripheral facility. And walked in today with severe pain in
So
the
this
right
person
eye.
would probably be blind, because very
Turns
difficult
out he
to
has
see through
uveitis.
all of this conjunctival tissue. And they also have it on both sides. This is called a kissing pterygium, right? Developing it on both sides. Obviously, these patients need to be
I just ran out of
counseled
paper at the
for,
corner.
sunglass
My goodness.
use, and you want to get at if there's any possible occupational exposure to dusts or hazards that may be precipitating this. The subconjunctival hemorrhage is painless bleeding beneath the conjunctiva. So the conjunctiva itself covers many fragile vessels, and those vessels are fragile enough to burst if there's high enough pressure. A subconjunctival hemorrhage is a symptom, it's not a diagnosis. So subconjunctival hemorrhage can be caused from many different things, but it itself is a symptom, not a diagnosis. It's a sign, something that you see when you're doing physical exam. So there's a lot of different causes of subconjunctival hemorrhage. Severe coughing, so this may be your patient who has COPD. Severe hypertension, patient on blood thinners, maybe an 80-year-old lady who's got her INR up to 2.5. She's at risk, not necessarily because these are fragile vessels, but because you can bleed easily. Heavy lifting, straining, constipation, vomiting, all of that we see there. Intra-abdominal pressure.
The left hand is coming at the back.
Trauma, that would be like rubbing on your eyes too roughly. That can
And he's holding a
destroy
dagger
those
in it.
vessels.
Unfortunately, I can't draw it
Because
because I ran out of paper.
In really young children, it can be a sign of vitamin C deficiency, and it can also be a sign
Olá,
of
bom noite.
And
Bom
then there's
noite.
also something called acute hemorrhagic
I think I have
conjunctivitis,
to learn
which
Portuguese
is
because,
happening with more and more frequency. It's caused either
I have a
from
lot of
coronavirus
people
or from
coming in
Coxsackie virus.
speaking Portuguese, and I don't understand Portuguese
So
as
here's
yet.
a subconjunctival hemorrhage. Note that it
So I
stops
think
at the
I have to start
limbus
learning
because
some Portuguese.
you have an
I do
abrupt
speak
transition
Spanish.
of tissue here. This is a closed system, so it stops at the limbus. So you shouldn't have any blood covering up the iris with a subconjunctival hemorrhage. So the symptoms, this is a painless and harmless problem, but it's very easily noted by a patient when they look at their eyes in the morning. My eyes are bleeding. And so these patients usually wind up in the ER or in the urgent care because you see your eye bleeding, if it's never happened before, you're going to be freaking out. So try to put yourself in the shoes of these patients. So this is usually noticed by a concerned patient or a parent if it's a child at home, or it may be noticed by you on physical or if you're rounding a patient. If the blood is red, you can assume that this was relatively recent, like within the last couple days. You should ask them about the common causes. So have you been coughing? Have you had any respiratory issues? Have you been doing any heavy lifting? Have you been working out? Have you been vomiting? Have you been constipated? All of those things can cause those causative factors that can lead to subconjunctival hemorrhage. So it's not so much the subconjunctival hemorrhage we're concerned about, it's what possibly caused it. Because some of these things, like vomiting and constipation and severe coughing, those can be things that might lead to another important diagnosis, and the subconjunctival hemorrhage was just a sign. So important to get towards that. But if it was just lifting packages or lifting weights or something of that nature, you can tell them just to take it a little easier. After a few days in the natural course of subconjunctival hemorrhage, if this is a limited, self-limited disease process, after a few days the blood will turn greenish or yellowish in color as the hemorrhage remits on its own, and it should be gone completely within about a week, or maybe 2 if it's severe. The diagnosis here is clinical. Like I said, the primary concern is what caused the hemorrhage. Usually it's accidental, but you should go through your list of possible causes of subconjunctival hemorrhages just to make sure, because if a patient comes in with a subconjunctival hemorrhage and they're constipated and they don't tell you they're constipated, this is a great time to treat them for their constipation, because then they don't have to come in a second time. The treatment is self-monitoring for improvement, so the patient just looks into their eyes and says, is this improving? Is this not? If it gets worse, they can come back in, but generally these tend to get better before they get any worse. And of course, address any secondary cause. Now is your chance. So on the USMLE, especially Step 3 or on Step 2 clinical skills, if you have a patient with subconjunctival hemorrhage, you want to look for the secondary cause and then do a workup for that secondary cause and then treat that secondary cause, because when a patient is in, you want to take care of all of them, not just the one thing that they're complaining about. If you have any questions, go ahead and let me know. We'll talk here about some other corneal problems. So we'll talk about the wide range of corneal dystrophies, as well as keratotorus and keratoconus. So the cornea is seen here. It's right here. It's this transparent portion consistent with the sclera that covers the anterior chamber. It's important that the sclera is transparent because it allows light to go through the lens and ultimately to the retina. That being said, Even though the cornea and the sclera are consistent, the cornea is much different tissue than the sclera. The cornea has to be transparent, and so it's made up of very organized collagen fibers as well as cells. The cornea gets its nutrients through the anterior aqueous, not through vessels, and that allows it to stay clear in its non-pathologic state. Okay, so corneal dystrophies, I don't want you to memorize all of these by any means, because you don't have to memorize these, you don't have to memorize the treatment, you just need to know when to suspect corneal dystrophy, because these are going to be treated by an ophthalmologist. So these are a group of progressive congenital eye disorders in which abnormal material accumulates in one or several levels of the cornea, and this disrupts the transparent property of the cornea as well as the corneal structure itself. So essentially what's going on is because you have a genetic mutation, the cells are creating something that they shouldn't be creating, and because of that you're disrupting that fine organized corneal layer. The vast
Having to
majority
put
of corneal dystrophies
a little
are
bit of
congenital,
more detail
and
into
among
small
those,
spaces,
most of
I
them are
mean,
going
that
to be
is
autosomal
a bit hard
dominant,
to
and
do.
that's useful because you have a patient who you're suspecting some kind of corneal
If you ever
problem
see
in
artists
because
draw
they
with
have
magnifying
corneal
glasses.
haze, corneal opacities.
Thank
One of
you,
the best questions
Sylvia.
you can ask is, do your parents
Thank you
have
for
any
subscribing.
problems? Do your parents have blindness? Does your have your parents ever had anything like this? That will be really
Thank you for
helpful
liking
in
my art.
establishing this diagnosis.
It helps a lot.
They tend to affect both eyes simultaneously, but they don't have to. But that usually is how it goes. Common symptoms to most corneal dystrophies, including a long-standing foreign body sensation or mild pain in the affected eye or eyes, and that just has to do with the chronic nature of this. The foreign body sensation is due to the fact that the cornea is a very sensitive structure. If you don't believe me, try and touch the middle of your eye and see how long you can do it. It's very, very highly innervated, very sensitive. So even the smallest changes, these dystrophies, will cause a foreign body sensation. The patient may experience halos when looking into light, and that's just because of the refraction from the foreign body, from the compound that's in the cornea, refracting back to the retina. Also, there's reduced visual acuity, and you'll see this particularly in patients where there's significant corneal haze. And then otherwise, the patient is normal, so their pupils will react to light and to accommodation. Extraocular movements should be normal. The only thing that's abnormal is the fact that these patients generally have some level of corneal haze, difficulty seeing, and a foreign body sensation. And this is a chronic problem, so this isn't something that came up a week ago, this is something that the patient has been dealing with for several months. So, among corneal dystrophies, and there's about 17 or 18 that are known, there's probably even more. The similarities are that they tend to be congenital. The symptoms are consistent. There's a long-standing foreign body sensation or mild pain in the eyes, decreased acuity as these corneal opacities come in. They don't affect other parts of the body. These are syndromes, but they don't affect anywhere else in the body except for the eyes. They also tend to affect both eyes similarly at the same time, and they're not caused by external forces. This is a genetic problem. This has nothing to do with trauma or infection. The differences lie in the particular location of the cornea that's affected. Some tend to be more superficial, some tend to affect the stroma more, and some tend to affect the endothelium more. Some have symptoms very, very early on, and some don't. The age of presentation can be different. Some of these corneal dystrophies present in childhood, others present in later adulthood. The extraneous materials that you would see if you were to do a histology would be different. So some of them will make lipids, some will make cholesterol, and that's certainly not the end. There's many more extraneous materials that can be secreted into the cornea. The prognosis can be different based on whether or not we have a good treatment modality for that particular corneal dystrophy, and that kind of works into the treatment. So here's our cornea here. This is just cut right down the middle. This is the outside here, and then this is the inside here, bordering on the anterior aqueous chamber. So you have your stratified squamous epithelium here. There's several layers. These cells regenerate and they move upward. So these outer cells are flat like a pancake. They're squamous cells. You see a lot of nucleus material. And the more inner cells are more of a columnar shape. Beneath that, you have Bowman's membrane, which serves as basement membrane for the epithelium. The largest section of the cornea is made up of collagen, and it is the stroma. And then down here, you see a little layer of cells. This is endothelium. And in between the endothelium and the stroma, you have what's known as Descemet's membrane. So the anterior corneal dystrophies affect the epithelium and the Bowman's layer. There's four. There's the epithelial basement membrane dystrophy, which is autosomal dominant, but it can be de novo. So the patient wouldn't have any parents who had it. The patient just developed the mutation on their own. Lish corneal dystrophy, which stands alone as the one X-linked dominant corneal dystrophy. Rice-Buckler corneal dystrophy, and Fiobenki corneal dystrophy. Those are both autosomal dominant. When it comes down to the stroma, there are several different types. Most, all but two, are autosomal dominant. Gelatinous droplet corneal dystrophy. There's the two granular corneal dystrophies, type 1 and 2. The two lattice corneal dystrophies, type 1 and 2. Macular corneal dystrophy, which is autosomal recessive. And Schneider crystalline corneal dystrophy, which is autosomal dominant. Like I said, you don't need to memorize these. And then the posterior corneal dystrophies, these affect the endothelium and the Descemet's membrane. There's congenital hereditary endothelial dystrophy, or CHED type 1. That's an autosomal dominant variant of the same disease as CHED type 2, which is autosomal recessive. And then Fuchs endothelial dystrophy is an autosomal dominant disorder. This has a distinguishing factor in that this tends to affect females more than men. It also tends to affect older women more than younger women. And then finally, posterior polymorphous dystrophy, which is autosomal dominant. Okay, so here's all your corneal dystrophies, the major types of corneal dystrophies. Do not memorize these. Here's some distinguishing factors, though. So, lattice corneal dystrophy type 1, macular corneal dystrophy, and Schneider crystalline corneal dystrophy, as well as both of the CHED dystrophies, these all have a tendency to affect young people.
Okay. What do I have
CHED
left?
1 and 2 will be apparent at birth. And so by apparent, I mean corneal opacities. And in case you're wondering, how do you tell a corneal opacity from a lenticular opacity? The corneal opacity will appear over even the iris, whereas the lenticular opacity, you won't see any opacities over the iris, just over the pupil. So CHED 1 and 2 will be apparent at birth. Signs of lattice corneal dystrophy may be present at birth, but symptoms do not typically present until the child is older, post-pubescent, or even early adulthood. Schneider crystalline corneal dystrophy can be present in the first decade of life.
If you're currently watching, comment your name. Let me write it somewhere.
Macular corneal dystrophy can be present around puberty. So these are some of the corneal dystrophies that tend to show up in younger people. On the other hand, we have Fuchs endothelial dystrophy. These tend to present in older people, and people who are in their 50s,
So
60s,
I'm gonna write
young.
names of those who commented in my channel today.
Women more than men, about 4 to 1 ratio.
So we have
a Fuchs endothelial dystrophy would be notorious for striking the otherwise healthy 60 to 70-year-old lady with no other health problems other than a progressive decrease in visual acuity, which she ascribes to aging. Very important to look in the patient's eyes. Don't always say, "Oh, you're an old person; it must be presbycusis." Maybe your lens is getting stiff. look into the eyes, you know corneal precipitates, obviously those shouldn't be there,
R4
and then you look back at her history questionnaire, and indeed her
and
father was totally
A4.
blind by age 75. And this is an autosomal dominant disorder, meaning that if a parent has it, you
Then risk
have a 50-50 chance of getting it. So all suspected corneal dystrophies are going to require consult to an ophthalmologist for specialized diagnostics and treatment. If they're a younger person, especially if it's an autosomal dominant disease,
Rengoku.
you should provide them with genetic counseling at some point in the future, and occupational therapy can be useful for helping
Rengoku.
these people maximize their potential.
He was the last person
Your
to
job
comment.
as the clinician, as the internist, as the pediatrician, as the ED doctor, is not to make the official diagnosis of which type of corneal dystrophy the patient has. That's done by the ophthalmologist. Your job is to suggest that this patient may have a corneal dystrophy, to rule out any other possible causes of corneal haze, such as keratitis, and then to identify these patients and send them off to the ophthalmologist. There's very little you can do for corneal dystrophies in a clinical setting, and the condition itself is not an emergency. So this might be a patient that if they say, oh, I've only noticed it for 1 or 2 days, you might get a fluorescein stain on it. But if they say they've had it for several weeks, maybe not.
I'm going to draw
It's probably
Naruto.
gonna be a corneal
Naruto
dystrophy.
pose here. So,
Okay, keratotorus, this is also known as pellucid marginal degeneration, is an idiopathic degenerative corneal
we're going to
condition
make this one
characterized
a quick
by
one.
abnormal thinning of the stroma. And the stroma is part of the cornea, so when the stroma thins, the cornea thins. You also have a thinning of Bowman's layer, possibly other structures, but it's primarily the stroma. And the bulk of this thinning happens below the horizontal midline of the cornea and then out along the periphery. So if you think of a clock, you would think of, if you were to take out the inner circle of the clock from about 4 o'clock to 8 o'clock. So the periphery on the bottom of the eye. And this shape creates an irregular astigmatism. Remember, astigmatism is just due to an abnormally shaped lens or an abnormally shaped cornea, and the result of that is that you're projecting different dimensions in different areas, either in front, on, or behind the retina. And so this creates an irregular astigmatism. So a patient presenting with new astigmatism, this is a possible diagnosis. Typically, keratotorus affects both eyes, not just one. The symptoms include gradual decrease in visual acuity, distorted images, symptoms that are consistent with astigmatism. Oftentimes, the patient has seen an optometrist for glasses, but the prescription keeps changing because keratotorus, pellucid marginal degeneration, is a progressive disease. In some cases, the patient will have extreme pain. In those cases, it will reflect a corneal perforation, but that's rare. So for diagnosis, what you're going to do is a slit lamp examination, and you're going to do corneal topography. And the corneal topography will help you identify how thick the cornea is and in which areas. And so if you notice that the cornea is thinner down at the bottom along that 4 o'clock to 8 o'clock line, then your suspicion for keratotorus goes up. The treatment, 88% of these patients will be managed by eyeglasses or contact lenses. They'll need frequent follow-up with an optometrist.
I can't find my eraser.
They're going to need changes in their prescription relatively frequently, or more
So I'm going to be using
12% of these
the
patients
Faber-Castell eraser.
will be candidates for phototherapeutic keratectomy, but the primary
See what it does?
treatment for
That is why I don't
keratotorus
use it.
is eyeglasses or contact lenses. Keratoconus is an idiopathic degenerative disorder of the cornea characterized by degeneration of the peripheral corneal structures. So if you think of the cornea as a globe, as a dome, if you're degenerating all the area around it, with the exception of the middle, then that ball, that globe, is going to turn into a pyramid. And this is where we get the word keratoconus. So that change in shape will certainly cause refractory issues. Remember that the cornea has a refractory index of about 45 to 50 diopters. So as the shape of the cornea changes, it's going to cause refractory issues. It can cause astigmatism as well as monocular diplopia. Most commonly, keratoconus is diagnosed in the adolescent years. So the symptoms are distortion of images, decreased visual acuity at all distances, monocular diplopia, difficulty with night vision, and halos. And again, here we're going to do a slit lamp examination for corneal topography. We want to get
Something
an
off
idea
about
of
my
what that
eyes.
cornea
My
looks
goodness.
like. Because a keratotorus versus a keratoconus versus a normal cornea look completely different. And the treatment here, there's abundant options. Contact lenses can be used, special contact lenses, to scleral lenses,
I think they're
to
too
several
close.
different types of surgery, including also corneal transplant.
Yeah.
So here's an example of keratoconus. If you look up really closely, you can see that this cornea
I don't know if it's
is
better.
relatively normal on the front, but it's thinned out along the sides. And it makes that cone shape. It's not a perfect cone, but you can see where they get the word keratoconus. Hello again, everybody. We're going to talk here about photokeratitis. So this falls under the disorders of the cornea. It's closely linked to keratitis in as much as it has similar symptoms: red eye, tearing, photophobia. However, there's a major difference in that photokeratitis is caused from UV radiation, whereas these other causes of keratitis that I spoke about in a different section, these are caused from infectious agents. So I wanted to separate this out because this has a little bit different etiology and a little bit different treatment. So in addition, we're also going to talk, not in this section, but later, about corneal abrasion as well as some other disorders, including the corneal dystrophies. So this is the cornea here. That would be this layer that sort of looks like it's bulging out here. I don't know if it really bulges out that much, but the cornea is consistent with the sclera, which is the white of the eye, and you have here a clear layer. So the cornea is clear. It's not white like the sclera, and of course that makes perfect sense, because if it weren't clear, then you wouldn't be able to conduct light through the lens and ultimately to the retina. So the cornea is clear, and it's made up of a couple thin layers of cells and collagen. Collagen is what makes up the stroma, and that's the largest portion of the cornea. But it is clear, it has no blood vessels, it gets its nutrients solely through the tear film and through the interior aqueous. So here is a histology of the cornea, and you don't need to memorize this by any means. This is step one stuff, but I just added it in here to sort of help wrap your head around what the cornea is, what it looks like. So this is on the outside here. This is outside of the body. This is in towards the middle of the globe on the left side here. So on the outside, you have an epithelium, and that is a stratified squamous epithelium. You have a thin layer here, that's called Bowman's membrane or Bowman's layer. Then this thicker layer, the thickest layer of the cornea, is all stroma. It's called the stroma, it's just made up of collagen. You have Descemet's membrane, which is the basement membrane for the stroma, and then you have an endothelium. And then interior to that would be your anterior aqueous. So photokeratitis is a disruption of the corneal epithelium due to UV radiation exposure, which results due to the disruption in a mild inflammatory response which involves the cornea and also the conjunctiva as well. UV light is the most common cause of radiation injury to the eye, and this makes sense that it affects the cornea because the cornea absorbs most of the UV radiation. Now, this isn't something that you're going to get
Welcome to my
if you go
channel if you want
outside
to.
and go and get your mail, or even if you drive a few miles in in the sun. This is something that you get from very typical risk factors. It's not something that you get just from incidental daily exposure to the sun. So what are some of these risk factors? Well, here where I work in Minnesota, we see a lot of skiers and snowboarders that come in with symptoms consistent with keratitis. And that is because the snow reflects 80% of UV radiation. And so because of that, if you consider it reflects 80% of the radiation, it doesn't mean that it reflects 80% of the brightness, 80% of the UV radiation. It's almost like you're staring into the sun while you're skiing or snowboarding. And so very, very important that skiers and snowboarders wear sunglasses. Also, people who use snowmobiles, anything where you're out in the snow for a long period of time. You also see this with indoor tanning beds. Certainly, you're at much higher risk to get photokeratitis if you're in one of those indoor tanning beds versus if you're just outside tanning. Flood lamps, halogen lamps, and then welders. Welders use a tool that causes UV radiation. I'm not exactly sure how that works, but welders use it's an arc, so they call it arc keratitis, carbon arc keratitis, or welder's keratitis. Okay, so the symptoms are just like any kind of keratitis. Eye discomfort, usually it's a foreign body sensation, mild to moderate pain. However, in photokeratitis, typically it's going to be bilateral because both eyes are exposed at the same time. Whereas in this regular old keratitis, infectious keratitis, it may be that just one eye is infected. That's perfectly possible, if not more common. But in photokeratitis, it's usually a bilateral presentation. And like I said, it's either a foreign body, gritty sensation, or mild to moderate pain. This is also combined with a marked photophobia, and that just reflects what the cause is. So the patient will not want to open their eyes. Now, photophobia is a symptom with any keratitis, but photophobia will be specifically marked in photokeratitis. You also see conjunctival injection, which represents the fact that inflammation has included the conjunctiva tearing and then a decreased visual acuity, and that's due to any inflammation in the cornea, as well as the superficial punctate keratitis, which you're going to see in a little bit, which is kind of one of the diagnostic hallmarks of photokeratitis. On exam, you may note lid edema. You can note hyperemia of the palpebral conjunctiva if you revert the lids. In very severe cases, you may see a diffuse corneal haze. I've never seen one in a photokeratitis case, and I've probably seen 7 or 8 of these. So, just back in the day, the Inuits, which are a native population in North America, used to use bones to shield their eyes from the UV radiation. They live up in the Canadian Arctic. Of course, dogs and other animals that are used for service purposes or for recreational purposes benefit from having sunglasses. I'm not sure if this is the common way that they wear them, but it looks kind of cool. And then this is typically how skiers and snowboarders will wear their sunglasses. Very important to prevent this. So the differential for photokeratitis is, of course, another cause of red eye. So our differential for red eye specifically includes conjunctivitis, acute anterior uveitis, acute angle closure glaucoma. With photokeratitis, the patient will typically have a normally reacting pupil, and that will set it apart from acute anterior uveitis or an acute angle closure glaucoma. In some cases, if it's really, really severe, the patient may have a reactive meiosis, but typically the patient will have a normally reactive pupil. Visual acuity is usually slightly reduced, and that stands in contrast to the acute angle closure glaucoma, where the patient's vision will be extremely reduced, usually just to hand motions, and conjunctivitis, where the patient's vision is not reduced at all. There may be tearing, but there's never any discharge. Other causes of keratitis should be in your differential, as well as corneal abrasion, but photokeratitis can often be connected to a preceding event, especially if you're working up in the northern areas, skiing, snowboarding, snowmobiling, being outside in the snow, where the patient was exposed to high amounts of UV light.